Okay, so let's get started with the questions. First question. The entire surgical staff of an organization has been working on its teamwork and communication skills. One day during a procedure, a surgeon lost his temper with the circulating nurse because he thought the nurse was not moving fast enough and was slowing him down by asking him to clarify the situation. As she continued to ask for clarification, he flung a bloody sponge at her and yelled for her to stop talking for 1 minute so he could think. As a patient safety officer of the organization, what would you recommend be done immediately? It's a fairly straightforward question. This is an unacceptable scenario. If the nurse is asking for clarification, she is doing the right thing, right? In a patient safety culture, that would be the right thing to do. If she's not comfortable with what she's seeing, she should be raising queries and she should be doing it in a respectful manner, which it sounds like she's doing. She's asking for clarification. She's not blaming the surgeon, she's only asking for clarification. So what she did was the right thing. And so what are your options? What would you do? So clearly the surgeon's behavior is unacceptable, because what he's doing is he's diminishing the psychological safety of the operating room. So he's going against the grain of a fair and just culture in an organization, right? He's undermining the safety culture of the operating room. So it's clearly unacceptable. What should you be doing? The first step, the first thing clearly that you have to do is the surgeon should be asked by the organization's leadership to apologize to the nurse. Why is that important? Because through that, you will be sending an organization to the you'll be sending a message to the other people in the organization that such and accept that the organization cares about safety culture, about psychological safety of the staff, and the organization wants to it wants to make staff feel comfortable to point out safety issues and seek clarification whenever they see something going wrong. Okay, so that would be the first thing they would need to do. Now, you will not do first the surgeon be monitored for similar behavior over the next few months. No, clearly you will not do that, because monitoring is something that you do for non-urgent kind of issues, or when when you have a process that is moving along in a stable manner. You want to monitor it to see that it doesn't go down or it doesn't get worse. But clearly this is something that needs to be tackled immediately, and so monitoring would not be appropriate. Third, the surgeon be required to undergo further training in teamwork and communication skills. That could be something that you have to get the surgeon to do. Definitely, the surgeon may require additional training, but that's not the first thing you will do, right? It'll come later. It'll come later on. And fourth, a thorough review of the teamwork and communication skills training provided to surgical staff. That may also be something that you need to do as a patient safety officer. It's simply not the first thing you will do. Okay, so I want you to take a good look at this one. So answers 2, 3, and 4 all are right, all are correct. But in out of these three, the most appropriate or the most immediate thing you would do would be to ask the surgeon to apologize. The second question: for the purpose of improvement, assessment of safety culture in a hospital is best conducted at the level of the unit. Safety culture, individual is clearly it's too small. It's too small a unit to really understand the culture of an organization. If you do it at the level of the hospital, you will probably miss some nuances that you can get from each individual unit. Because remember, each of these units, which are also called clinical microsystems, right? The front lines of providing care, right? Each medical floor, each outpatient department, each clinical unit, they have their own culture, and that culture is shaped by all the people working there. So safety culture is best reflected at the unit level. Okay, so you will probably do a safety culture at the system level. You will to get an overall picture of how the system performs and how the hospital performs. But when you're actually going to implement an improvement program, you would want to look at the unit level data to find out how that particular clinical microsystem is performing. Okay, now within a hospital, the third question: within a hospital, which units are preferred locations to target improvement work in patient safety? Okay. Now the answer. Now units with high, the correct answer is option one. Units with high rates of adverse events and less positive patient safety culture. Now, why is it important to choose this unit? It's because of the urgency of addressing patient safety in that unit. Okay. Now here, if they have a high rate of adverse events, that means clearly their processes are out of whack. It needs urgent fixing. If they have a less positive patient safety culture, it means that the probability or the likelihood that harm and errors will happen and patient safety will be adversely affected is very, very high in those units. Okay, so these units clearly they are the first ones on your priority list. They should be the first ones you address. Units with high rates of adverse events and less positive patient safety culture. Now, fourth question: for which of the following situations is closed loop communication most beneficial? Okay, so before answering the question, let me ask you, what is closed loop communication? Right. So Renee says read back and verify. That is an example of a closed loop communication. So in effect, what it means is if I'm communicating something to Michelle and I give her some information. Here are the instructions for how the medicine should be given to the patient. And after I've concluded, after I've given the information, I say, okay, Michelle, can you just teach me back what I just told you? Or can you just tell me what I just told you? And Michelle then uh, sort of repeats her understanding of what I just conveyed to her and verifies. So that ensures that Michelle and myself are on the same page. Okay, so that is closed. So in effect, what you're doing is you're closing the loop of communication. I communicate to Michelle. Michelle verifies what I communicated. So we have closed the loop. That is closed loop communication. Now, where is it most beneficial? Where would it be applicable? Let's look at where it would be applicable. Now, when administering intravenous medications and fluids, um, you will be giving these intravenous medications and fluids to the patients, and there is no scope for the patients to verify that information back to you. Okay. Now, let's look at option three. When trying to get the physician's attention during an intense patient care period, clearly you will not use closed loop communication there because it's not you're trying to get the physician's attention for what, and you will not use closed loop communication, that too during an intense patient care period, clearly not. So that option is out. um, Fourth one, while obtaining informed consent from a patient, it could be used for option number four. Okay, while obtaining informed consent, because let's say you're going to perform a procedure on a patient. You describe the procedure to the patient, and you could right you could probably ask the patient to describe their understanding of that procedure. Informed consent is just you'll describe the procedure to the patient. You'll ask the patient if the patient is okay with that procedure. Does the patient understand the benefits and risks, etc.? And then they will sign on the form, right? So the only option is now where is option number two, that is during a handoff from operating room to the intensive care unit. Now, why is closed loop communication in this important? Now, it's been found that in healthcare, whenever there is a handoff, okay, what is a handoff? When the patient is, whenever care or patient or document or materials are transferred from one place to the other. Okay, so from one unit to the other, from one doctor to the other, or from a doctor to a nurse, or from the operating room to the intensive care unit, or from the intensive care unit to the medical floor, whatever. Okay, this is all handoff. Now, what has been found in research is that the likelihood of error, the scope for error and harm is maximum during handoffs. Whenever there is a transfer from one entity to the other, that is where there is a huge scope for error. Why is that? Because handoffs always require communication. And if communication is not effective, that can lead to harm and errors. Okay, so when a patient is being handed off from the operating room to the intensive care unit, there are instructions that need to be given to the intensive care unit. They should give the patient's status, maybe the patient's vitals, the continuity of care, whatever needs to be monitored, whatever needs to be, whatever medications the patient should receive, etc. So there are instructions that will be given from the operating room to the intensive care unit. And in order to make sure that the intensive care understands and has got the information correctly, they would want to read back and verify, or they would want to close the loop of communication. SBAR, now for those of you who don't know what SBAR is, SBAR stands for Situation, Background, Assessment, and Recommendation. And it is a worldwide known tool, and it's a very effective tool for communication between clinicians. So if a physician, if a nurse is trying to describe a patient's situation or providing some update to a physician on the phone, she would use this format. She will say, I'm nurse so and so, I'm calling about patient so and so. Situation is, and she'll describe what is the current situation of the patient. They'll say the background is, and she will say, she'll give the general background, the clinical background of the patient. The patient was admitted with so and so complaint, has a known history of blah blah blah, and was has been receiving this care, blah blah blah. And then right now we have this particular situation, and then she will say my assessment is, and she will give her impressions of what the case is, and she will either make a recommendation or a request. So she will say my recommendation is, the patient should be given so and so care or whatever, or she will say my request is that you come down and take a look at this patient immediately, or within the next couple of hours or whatever. So SBAR communication is a good tool. Now, I just want to qualify it a bit there. Now, SBAR is a general clinical communication tool. Okay, SBAR is applicable for handoff. So you could say that all handoffs require SBAR, but all SBAR is not handoff. All right, and SBAR sometimes does not involve closed loop communication. So a nurse could endorse, or a nurse could give a patient information in an SBAR format, but the physician doesn't have to close the communication loop. The physician could just say, "Okay, sounds good. I got the information. I'll come back and I come to the ward and take a look at the patient." So the physician doesn't have to close the loop. All right. So the next question is, which of the following tools may be used to prioritize actions to reduce risk of failure? So it sounds like something that you are doing proactively to reduce harm and errors, etc. And whenever we are talking about proactive tools, the first one that should come to your mind is failure modes and effects analysis, right? So if you look at the options, right? Option number 2 is root cause analysis. Root cause analysis is a reactive tool. That means it is something that you do after a failure has occurred to find out why it occurred in the first place. A focus group is not something that you would usually do to reduce risk of failure. It's not an applicable tool there. Control chart, again, it's for data and information management. It's not to reduce risk of failure. So failure modes and effects analysis is clearly the option. Okay. Now, which of the following is not an appropriate red rule? So remember, we talked about red rules. Red rules means anybody in the organization can stop the line. They can ask for the process to be stopped, uh, and the senior leadership of the organization should always support it. And there are no exceptions to a red rule. Meaning, red rules, whenever someone asks for a process to be stopped based on a red rule, it must always be respected, right? So these are the underlying tenets of a red rule. So which of the following is not an appropriate red rule? So let's look at some of the examples here. So when a midwife is concerned at the bedside and asks for an obstetrician to come to the bedside, he or she should come in a timely manner. Now, is this applicable for a red rule? sounds like it's an appropriate red rule. Why? Because it's an important safety issue, right? If there is a woman in labor and or a pregnant woman, and if a midwife has some concerns, uh, where the obstetrician should obey that red rule and come to the bedside. When he comes to the bedside, he or she may realize that it was not an urgent situation, or it was not an emergency, or whatever, but doesn't matter, because if it was really an emergency situation and the obstetrician did not show up, then the scope for harm would have been very, very high. So it sounds like something that would go into a red rule. Elective induction of labor prior to 39 weeks for non-medical reasons is not permitted. Again, for safety issues and for labor and delivery related issues, that also sounds like a good red rule. Then, third one, if there is a discrepancy in the sponge count during surgery, the patient should have an X-ray. Uh, Again, because as you know, surgical errors during surgery, during the whole process of surgery, is one of the major reasons for errors in a healthcare setting. So, discrepancy in sponge count definitely goes into a red rule. Now, a nurse should observe 5 rights of medication administration when administering medication. This is, observing 5 rights of medication administration is it's a good practice to follow, right? But it's not, it's not something that is appropriate for a red rule. So this is something that would fit into a quality improvement sort of project. Same thing applies for hand hygiene. The 5 moments of hand hygiene, if you will. That is something that will go into a quality improvement sort of framework, not a red rule. The next question is: an acute care facility performed FMEA analysis of the medication administration process. For the final step of the process, an identified possible failure mode was the availability of discontinued medications for use. Its likelihood of occurrence, likelihood on detection, and severity of impact were given a rating on a scale of 1 to 10. So occurrence was 4, detection was 8, and severity was 6. What action should the FMEA team recommend to reduce the occurrence of failure? Now, before I answer this question, let me just recap the FMEA process for you. In failure modes and effects analysis, what you will do is you will identify um, like big areas for patient safety, big areas of concern for patient safety in your hospital. For example, medication administration, or surgical processes, or safety of infants in your hospital against abduction, etc. So these big processes, and what you will do is you'll identify all the sub processes within that bigger process, and for each of the sub processes you will identify the failure risk. And how you do that is you give a rating for the likelihood of occurrence. How likely is that something like this could really go wrong? Okay, so that is likelihood of occurrence. And then the second question is, if it really goes wrong, how likely is it that it will be detected? Okay, so is there a low likelihood of detection or a high likelihood of detection? Now, if it is a low likelihood of detection, that means the problem is serious, right? That means something wrong happens and you won't even realize it. So low likelihood of detection always gets a higher score. Remember that. Remember that. Okay. So low likelihood of detection means higher score. So if there is here, like it says that detection has a score of 8, that means it has a low likelihood of detection. Then likelihood, the severity, the rating for severity is 6. That means if it goes wrong, how severe will the effects be? So it is a 6. And how you will, based on these 3 scores, you calculate what's known as a risk priority number. So you will multiply these 3 numbers, and that will give you a risk priority number. And whichever sub process has the highest risk priority number needs to be addressed first. All right. Okay. So that's just the background on FMEA. Now here, what are we looking at? What we found is one of the possible modes of failure was that discontinued medications may still be available in the hospital. Okay. And what they found is that the likelihood of detection is going to be very low. That means if it really goes wrong, now the likelihood of occurrence is only 4. That means it is not something that will happen frequently, but if it happens, the likelihood that it will be detected is very less. Okay, so what should they do now? So the actions are: introduce dedicated medication nurses. Would you really do that? No, because putting nurses, dedicated nurses, to look at that process, whose likelihood of occurrence is kind of low, is not very. It's not very smart in terms of resource management, right? So you would not do one. Second is implement an automated medication dispensing system. Well, you should have an automated medication dispensing system anyway. So, I mean, in spite of having an automated system, you could still run into this problem. So that does not solve your problem of the with the detection, right? Uh, so that detection problem is not solved here. Third is train staff to recognize early signs of drug toxicity. Um, Now, this the third, to recognize early signs of drug toxicity would mean that the error has already occurred, the failure has already occurred, and then you're trying to mitigate the harm. So, is it really a proactive step? No, that means the failure has already occurred, right? So, 3 is clearly out. Fourth is implement pharmacy rounds to remove discontinued medications from patient care units is the most appropriate thing, right? Because then you are proactively taking a step to prevent the occurrence in the first place. Because remember, if it occurs, the likelihood of detection is very low. That means the best step, the wisest thing you could do is to prevent the occurrence in the first place. So the next question is, what elements of care should patients be asked to teach back? Okay, now again, what does teach back tell you? What sort of communication is it? Teachback is another example of a closed loop communication, right? Now, what elements of care? Contact information for getting help? Yes. Importance of keeping the follow up visit? Yes. Self care on return home? Yes. So, all of the above. All of the above, you can ask the patient. So, these are instructions generally which you give at the time of discharge from the hospital. So, discharge instructions are basically appropriate for teach back or for closed loop communication. In improving safety and reliability in the operating room, the organization has designated a clinical leadership group to own and drive the work. What should the next step be? Okay. So, what is our task here? To improve safety and reliability in the operating room. And already a team has been designated, the clinical leadership group has been designated. What should the next step be? So, develop performance measures for operating room. No, that is something that happens later on. Implement structured communication techniques in the operating room. Now we are jumping to solutions, so solution should not come up front. Uh, Provide teamwork training for operating room staff. Again, that is one of the interventions. That is one of the solutions. So that will come later on. 3, review the cultural assessment information about operating room. That sounds like something that should be done upfront. So 3 is the best option. Is as part of its initiative to improve prophylactic perioperative antibiotic utilization, an acute care facility aims to administer perioperative antibiotics within 1 hour of surgical incision in 100% of the cases. To whom should the responsibility of timely perioperative antibiotic administration be assigned? uh, Anesthesiologist, surgeon, scrub nurse, circulating nurse. So here, in this question, you just need to think in terms of the process owner. Okay, remember the term process owner. You are in the operating room and you have bunch of people. So surgeon is the process owner for the actual surgery that takes place. The scrub nurse is the process owner for providing all the all the equipment. I mean the equipment and stuff to assist the surgeon. The circulating nurse basically ensures that the whole um, process within the operating room goes according to plan. And the anesthesiologist is the process owner for anything to do with medications and anesthesia and antibiotics, etc. So it would be best to give the responsibility of timely perioperative antibiotic administration, the leadership of that, to the process owner for medications, which is the anesthesiologist.